Today we are going to discuss on the drugs that act on the uterus. Either the drugs acting on the uterus, they can increase the contractility of uterus, that are called uterine stimulant or abortifacient, and some drugs decrease the contractility of uterus. They are called uterine relaxant, also called tocolytics. So, uterine stimulant and relaxant, the drugs that act on the uterus, they either act on the endometrium or the myometrium. On the endometrium, the drugs mainly acting are estrogens and progestins and the antagonist. The drugs that act on the myometrium, they either modulate the autonomic innervation, that is parasympathetic and sympathetic nervous system, or they act directly on the myometrium. Now today we are mainly focused on the drugs acting on the myometrium directly. So drugs acting on the uterus can primarily affect the endometrium and the myometrium. The most important drugs affecting endometrium are estrogens and progestins, and they are antagonists. Myometrium receive both sympathetic and parasympathetic innervation. Autonomic drugs, they can affect its motility by acting via those innervations. However, directly acting drugs are more important and they have got more selective action. So they are more important to us. The responsiveness of myometrium to drug is markedly affected by the hormonal status of the patient and the gestational status. Now, uterine stimulant, we know that the posterior pituitary, they release oxytocin and vasopressin. What's the role of oxytocin? They increase uterine contraction. So, posterior pituitary hormone oxytocin and this amino oxytocin is the primary drug. Ergot alkaloids, where we have read it? Ergot alkaloids, in which chapter? Migraine chapter, where ergotamine is used for basically in acute attack of migraine. So ergot alkaloid is Argometrine. They have got lesser role in migraine. They have got more role in increasing the uterine contraction. So Argometrine, also called ergonovin and methyl ergometrine. Prostaglandins like PGE2, PGF2 alpha, methyl PGF2 alpha and misoprostol. Misoprostol আগে কোথায় পড়েছি আমরা? Misoprostol is the drug of choice in sorry, peptic ulcer এ পড়েছি. It is a drug of choice in NSAID-induced ulcer. And miscellaneous that include ethacridine and quinine. Quinine টা কোথায় পড়েছি? Quinine টা পড়েছি তো? হ্যাঁ? Quinine জোরে বলো। ম্যালেরিয়াতে পড়েছি, right? So coming to the oxytocin. Oxytocin is a peptide hormone. It's a nona peptide hormone secreted by the posterior pituitary. কোথায় synthesize হয় oxytocin টা? Sorry, posterior pituitary store হয়, synthesize হয় hypothalamus এ. So they are synthesized both oxytocin and ADH, that is vasopressin. They are synthesized within the nerve cell bodies in supraoptic and paraventricular nuclei in hypothalamus, transported down the axon. They are stored within the nerve endings of the posterior pituitary hormone. They are stored in both oxytocin and vasopressin. They are stored in separate axon neurons, basically nerve cell bodies, and stored as granules by complexing with a protein called neurophysin. Now there are certain stimulus factors that stimulate release of the hormone from the posterior pituitary. For oxytocin, they are coitus, parturition and suckling. While for antidiuretic hormone, they are hypertonic saline infusion, water deprivation and hemorrhage. And some non-specific stimulus that stimulate release of both are pain and apprehension. Now coming to the action of uterus, action of oxytocin on different organs, primarily on the uterus and the breast, and they also act on the cardiovascular system and the kidney. Now coming to the uterus, what does they primarily do? They increase the force of the uterine contraction and they increase the frequency of the uterine contraction. Estrogen, they sensitize the uterus to the oxytocin and they increase the oxytocin receptors in the uterus, while progestins, they decrease the sensitivity of oxytocin to the uterus. Now oxytocin are lesser sensitive in non-pregnant uterus and that during early pregnancy, and they are more sensitive in the later part of pregnancy. During the basically labor time, there is a sharp increase near term and there is a quick fall of sensitivity of oxytocin to uterus during puerperium. At term, the increased contractility is more restricted to the fundus and the body of the uterus, while the lower segment of the uterus is relaxed. How does it help? It causes better descent of fetus during the labor. Action of oxytocin, as I said earlier, is independent of the autonomic innervation of the uterus. Now these are oxytocin receptors, these are basically GQ type of G protein coupled receptors, and they cause increased influx of calcium in the uterine myometrium, uterine cells, and they also by IP3 they causes increased intracellular release of calcium. So increased availability of calcium causing increased contraction. The number of oxytocin receptors increases markedly during the later part of pregnancy. There is also release of prostaglandins from the endometrium during the later part of pregnancy, and that may contribute to the contractile response. Number 2 action is on the breast. What does they cause? They cause increased contractility of the basically myoepithelium of the mammary alveoli, and they cause better forces milk into the bigger milk sinusoids. That is called milk ejection reflex. They does not increase the secretion of milk, but they basically increase the force of milk ejection into the bigger milk sinusoids, and that is basically more precipitated by suckling of the breast by the infant, so that it may be easily sucked by the infant. Oxytocin is used in cattle to facilitate milking. Coming to cardiovascular system, the dose we use in obstetrics generally does not have any impact on the cardiovascular system, but higher dose can cause vasodilatation, and vasodilatation will release in the fall of blood pressure and reflex tachycardia. The action is most marked in the chicken, and hence it is utilized for the purpose of bioassay of oxytocin. The umbilical veins are markedly constricted and possibly oxytocin play a role in the closure of the umbilical veins at birth. Coming to the kidney, at higher doses, oxytocin have ADH-like action, antidiuretic hormone-like action. So at higher dose, urine volume is decreased. There is antidiuresis, and hence pulmonary edema can occur if larger amount of oxytocin is infused with large amount of IV fluid in term pregnancy. Conventional doses are without any effect. So the dose we use in obstetrics generally does not have any impact on the cardiovascular system, nor on the kidney. Physiological role, they have got role in during labor time, in the milk ejection reflex and neurotransmission. In labor, oxytocin is released during labor, and during labor, uterus is most sensitive to the oxytocin. Prostaglandins and platelet activating factor are complementary to the oxytocin. Milk ejection reflex, suckling of the breast by the infant induces oxytocin release from pituitary that cause contraction of the myoepithelial cells in the mammary alveoli, and thus ejection of milk is facilitated. These cells in breast are more sensitive than myometrium to the oxytocin. Milk ejection reflex is absent in hypophysiectomized animal, and that shows that oxytocin has a greater role in milk ejection reflex. Neurotransmission, oxytocin appears to function as a peptide neurotransmitter in oxytocinergic neurons in hypothalamus and brainstem. Pharmacokinetics, we all know that oxytocin is a peptide hormone, so it can't be given orally. It is given generally intramuscularly or intravenously, and rarely it can be used as intranasal formulation. It is rapidly degraded in the liver and the kidney, so half-life is very low, around 6 minutes to 12 minutes, and basically it is further decreased during the labor time. Pregnant uterus and placenta, they elaborate certain peptides called oxytocinase that help in the breakdown of oxytocin. Uses of oxytocin: number 1, induction of labor; number 2, uterine inertia; 3, in the postpartum hemorrhage, breast engorgement, and the oxytocin challenge test. Induction of labor, they help in inducing the labor, oxytocin. When? In case of post-maturity, in case of prematurity, oxytocin should not be used in normal labor. In prematurity, it is used in toxemia of pregnancy. In premature pregnancy, why it should be induced? In certain conditions like toxemia of pregnancy, when the mother is diabetic, erythroblastosis, ruptured membranes, or the placental insufficiency, that requires induction of labor. For this purpose, oxytocin is given by slow intravenous infusion to control the uterine contraction. Now, before starting infusion of oxytocin, certain points has to be considered. Okay, number 1, there should be no cephalopelvic disproportion, so that obstructed labor will develop. Presentation should be correct. Fetal maturity should be considered, particularly fetal lung maturity. There should be no cephalopelvic disproportion, no placenta previa, and no fetal distress, and no uterine scar. Uterine contraction should be closely monitored, and it should be stopped when there are strong enough uterine contractions. Uterine inertia, when the uterine contraction is feeble. To augment the uterine contraction, oxytocin can be used. When uterine contractions are feeble and labor is not progressing satisfactorily, it should not be used to hasten delivery in normal pregnancy. Why? Because it can cause fetal mortality. Before deciding to use an oxytocin for strengthening uterine contractions, all the conditions should be met as discussed previously. That is, no cephalopelvic disproportion, fetal lung maturity, no placenta previa, no uterine scar, and others. Too strong contractions can be catastrophic. Use only should be made in selected cases by experienced people. Why oxytocin is preferred over Argometrine in induction of labor? Why oxytocin is preferred over Argometrine and prostaglandin? So, these questions may come because of number 1, short half-life, and it is used as slow IV infusion. So what is the advantage? The uterine contractions can be closely monitored as it has got short half-life. When we increase the dose of intravenous infusion, the contractile response increases spontaneously, quickly. The response can be obtained, and if decreased, the response can be obtained quickly again. So, because of short half-life and slow IV infusion, intensity of action can be controlled and can be terminated if required urgently. Number 2, lower concentration of oxytocin when used allows normal relaxation in between. Basically, oxytocin, they cause phasic contraction. That means contraction between two contractions, there is uterine relaxation. So, lower concentration allow normal relaxation in between contraction, and thus fetal oxygenation is not impaired. Unlike in case of Argometrine, where even moderate dose can can increase the basal tone of uterus, and so fetal oxygenation can be impaired. Number 3, lower segment is not contracted, so fetal descent can be hastened. Fetal descent is not compromised, unlike in case of Argometrine, where both fundus body and the lower segment of uterus is contracted. So, fetal descent is compromised. Uterine contractions are consistently augmented. Postpartum hemorrhage. In postpartum hemorrhage, oxytocin can be used. It is 5 international unit of oxytocin is injected intramuscularly or via IV infusion for an immediate response, particularly in case of hypertensive subject or in toxemia of pregnancy where Argometrine are contraindicated. It acts by forcefully contracting the uterus so that it compresses the blood vessels passing through its meshwork, and thus it arrests hemorrhage. Breast engorgement, it may occur due to milk ejection reflex response of the oxytocin. It may occur due to breast engorgement can be seen due to inefficient milk ejection reflex. Oxytocin is effective in patients of breast engorgement. Intranasal spray may be given few minutes prior before suckling. Adverse effect, injudicious use of oxytocin can produce too strong uterine contraction, forcing the presenting part through the incompletely dilated birth canal, so that there is soft tissue injury of the fetus and the mother. Water intoxication, and that can also result fetal asphyxia and death, rupture of uterus. Water intoxication, when larger doses of oxytocin are used with IV infusion due to ADH-like action, there is pulmonary edema and water intoxication. It is a serious and fatal complication. Coming to the next topic, Argometrine and methyl argometrine. These are basically amine ergot alkaloids. They are used mainly in obstetrics. Ergotamine, they are mainly used for the migraine patient, and Argometrine, they are mainly used in obstetrics. Both have similar pharmacological property. Pharmacological action on uterus, on the cardiovascular system, central nervous system and gastrointestinal system. Uterus, they increase the force of contraction, frequency of contraction and the duration of uterine contraction. At low doses, contractions are phasic, that is, there is relaxation of uterine muscle in between two contractions, but even in moderate dose, the basal tone is increased, and higher dose relates to at higher dose uterine contracture result. Gravid uterus is more sensitive, like oxytocin, especially at term and in early puerperium. Their stimulant action also involve lower uterine segment, unlike oxytocin. The uterine contraction possibly occurs due to the partial agonistic action on serotonergic 5-HT2 receptor and on alpha adrenergic receptors. Coming to cardiovascular system, like ergotamine, they also constrict blood vessels, but their action is weaker. So much weaker vasoconstrictors than ergotamine, and they have got low propensity to cause endothelial damage. The dose we use in obstetrics generally does not have any impact on the cardiovascular system. Central nervous system, no overt effect at usual dose, but at higher dose, because of complex interaction of partial agonistic antagonistic interaction with adrenergic, serotonergic and dopaminergic receptors, some basically can produce complex actions. Gastrointestinal system, high dose can increase the peristalsis. Coming to methyl ergotamine, Argometrine, 1.5 times more potent than Argometrine, and but other actions are less marked. And as the other actions are less marked, so methyl Argometrine today is more commonly used than Argometrine. Pharmacokinetics, unlike amino ergot alkaloid, that is ergotamine, they are rapidly and nearly completely absorbed from the oral route, partly metabolized in the liver and excreted in urine. Plasma half-life around 1 to 2 hours. Effect of a single dose lasts 3 to 4 hours. Adverse effect, they are lesser toxic than ergotamine. Hardly any complication arise when correctly used. Nausea, vomiting and rise of blood pressure can be seen. They can decrease milk secretion because of inhibition of prolactin release, and that is due to dopaminergic effect. Ergotamine should be avoided in peripheral vascular disease. Why ergotamine should be avoided in vascular disease, hypertension, toxemia? Because of their vasoconstrictor property. So it should be avoided in patients with vascular disease, hypertension, toxemia. In sepsis may cause gangrene because of vasoconstriction. Liver and kidney disease, they are contraindicated during pregnancy and before the 3rd stage of labor. Uses, it can be used to control and prevent postpartum hemorrhage. Not in all patients. Argometrine should be used to prevent postpartum hemorrhage only in selected case where it is required. After caesarean section or instrumental delivery, it can be used to prevent uterine atony by increasing the basal tone of uterus. To ensure normal involution of uterus post labor, and they are also used for diagnosis of variant angina. During coronary angiography, if Argometrine is used in low dose, that causes vasoconstriction of the reactive coronary vessels, and thus they are helping in the diagnosis of variant angina, although not used nowadays because of high risk. Prostaglandins, PGE2, PGF2 alpha, methyl PGF2 alpha, they can be used. They are potent uterine stimulant, especially in the later part of pregnancy, and also they help in ripening of the cervix. Number 2, misoprostol, they produces the same response, they have got lesser side effects. So they are being used for obstetric indications as well. Coming to the next topic, uterine relaxants. Uterine relaxants, also called tocolytics. They are used for inhibiting or decreasing uterine contractions. Where they are used to delay or postpone the labor where required. They are used to arrest threatened abortion, and they are used in dysmenorrhea. Prevention of premature labor in those at higher risk due to past history can be attempted by administration of large dose of progesterone in the later half of pregnancy with some success. Now, no clearly satisfactory drug is available till today, since none of them has been shown to improve the fetal outcome. Why we will use the uterine relaxant? To improve the outcome of the fetus and the mother. But till now, no drug has shown to improve fetal outcome. An attempt to delay premature labor is likely to succeed if cervical dilatation is less than 4 cm and taking up of the lower segment of uterus is minimal. What do we mean by taking up of lower segment of uterus? As the labor progresses, the lower segment of uterus, they basically merge with the upper segment of uterus, and that is called basically taking up of the lower segment of uterus. Measures to delay labor should not be undertaken. কখন করব না, ইউজ করব না if there are ruptured membrane, antepartum hemorrhage, intoxemia of pregnancy, intrauterine infection and fetal death. What are the drugs available? Number 1, adrenergic agonist include ritodrine, salbutamol, terbutaline and isoxaprine. Calcium channel blockers, particularly nifedipine. Oxytocin antagonist, atosiban, magnesium sulfate, miscellaneous drug, ethyl alcohol, progesterone, general anesthetics including halothane and indomethacin. Ritodrine. Ritodrine is basically a beta-2 receptor agonist. It is a beta-2 selective agonist having more prominent action on the uterine muscles. They have got uterine relaxant action and it is approved to suppress premature labor and to delay delivery. But the problem is complications, cardiovascular complications that include hypotension, tachycardia, arrhythmia, pulmonary edema. Metabolic complications are there that include hyperglycemia, hyperinsulinemia and hypokalemia, and anxiety, restlessness and headache. Use of ritodrine to arrest labor has been found to increase maternal morbidity. Fetal pulmonary edema can develop, neonate can even develop hypoglycemia and ileus. These are the complications with the use of ritodrine. It should not be used if mother is diabetic, she is having heart disease or receiving beta blockers or steroids. Other adrenergic drugs, salbutamol, terbutaline can be used as an alternative to ritodrine. Isoxaprine has also been used to stop threatened abortion. Efficacy uncertain. Calcium channel blockers. We all know that uterine contraction occurs due to increased availability of calcium. So, if we use calcium channel blockers, they reduce the tone of myometrium and oppose contraction. They can be used to postpone labor if used early enough. Efficacy is comparable to the beta-2 agonist. Side effects are fewer. Although tachycardia, hypotension are prominent at doses which suppress uterine contraction, reduced placental perfusion can cause fetal hypoxia even, but that is not dangerous. Coming to atosiban. Atosiban is the oxytocin receptor antagonist. In clinical trials, it has been found to suppress premature uterine contraction and postpone the preterm delivery with fewer cardiovascular and metabolic complications. Magnesium sulfate. Magnesium sulfate is the drug of choice in toxemia of pregnancy to control convulsion. Right. Other conditions use kora jay. Magnesium hydroxide is used for basically as a laxative. Infused intravenously, it is the first line drug for prevention and treatment of seizures in preeclampsia and eclampsia. It is also used as a tocolytic by competing with calcium ion entry via ligand gated or voltage gated calcium channels. However, its use to delay premature labor is risky and is not recommended now. And last, the halothane. Halothane is a very efficacious uterine relaxant that is used as an anesthetic when external or internal version is attempted. external or internal version মানে জানো? প্রেজেন্টেশন অফ ফিটাস যেটা থাকে কি কি প্রেজেন্টেশন হয়? দেয়ার ইজ ভার্টেক্স। ফিটাসটা যখন মায়ের ইউটেরাসে থাকে তো ইট হ্যাজ সার্টেন প্রেজেন্টেশন লাইক vertex presentation when the head is down and the legs are up. There are bridge presentation, it's completely opposite, and there are other presentations as well. Now after 32 weeks generally the presentation does not change. When at 32 weeks we see that the presentation is different and we want to change the presentation, that is called version, which can be done by external version or internal version. In those cases the mother has to be basically anesthetized. Their halothane can be a good general anesthetic.